Good evening, everybody. My name's Duncan Boak. I'm the founder and chair of Fifth Sense, the charity for people affected by smell and taste disorders. And I'd like to wish you all a very warm welcome to Medicine and Me, Living with a Smell or Taste Disorder, the latest partnership between the Royal Society of Medicine and Fifth Sense, following on from the very successful face-to-face Medicine and Me we did together back in 2017. I just want to give a quick introduction to the event. I've lived with anosmia since 2005, when I lost my sense of smell as a result of a head injury. And it was the lack of any information, support, or even recognition that this could be a problem for me that left me spending over 6 years thinking that I was one of the only people on the planet with this mysterious affliction, which had an impact on my life in all sorts of ways. Fast forward to today, an awareness of smell and taste disorders has increased significantly, in no small part due to smell and taste disturbances being a common symptom of COVID-19. But if anything, this has only really increased the need for the work of our charity and highlighted the need for more and better medical services and support in this area. There's still a need for increased awareness, particularly amongst the medical profession, of both the impact that smell and taste disorders have on so many aspects of our lives, and also what can be done to help people, which is precisely why we're here today. Our stories, alongside the expertise of people who work in this field, are absolutely crucial to this increasing understanding. It was my story of losing my sense of smell that inspired me to start Fifth Sense. And Fifth Sense has, in turn, been a platform for others to share their experiences to then help educate others. The events that Fifth Sense has run over the years have always brought together patients, clinicians, scientists, and others with a passion for the sense of smell and taste, so that stories and information can be shared for mutual benefit, which is exactly what this evening's all about. We've got an absolutely fantastic lineup of speakers. So without further ado, I'm going to hand over to our first speaker this evening. Just before I do so, final thing for me for now, just to say that if you have any questions at any point, and then please use the Q&A button at the bottom of the screen, type your question in, and then that can be brought up to be answered by the panel later on. So without further ado, I would like to hand you over to Sian Riley from Red Pepper Nutrition, who's going to talk to you about the importance of nutrition and the challenges with food and drink.
Thank you very much, Duncan. Just share my screen now. Hello, so my name's Sian Riley, and I'm the founder of Red Pepper Nutrition. We specialise, we are specialist rehabilitation dietitians, specialising in traumatic injury. The majority of our clients we see brain injury, but we also see spinal cord injury and orthopaedic injury too. So if you were on Twitter last night, as most of us were, because we'd been locked out of Facebook and WhatsApp, then please do follow and connect on Twitter at Red Pepper Nutri. And I've just left our my email address there and the website address, which would be great to connect over. So today I'm going to talk about the importance of nutrition. The importance of nutrition specifically in brain injury rehabilitation, the important link between smell and appetite, and where smell loss fits into dietetics as a dietitian, and what can we do to help as professionals, but also as carers, family and friends as well. So you've probably heard of the phrase, my body is a temple, and our body really is a temple. It's a very busy temple that's getting lots of scratches and bangs all day long. In this temple, we have some workers, and these workers work 24 hours a day, 7 days a week to repair and maintain our temple. These workers go down to the storage rooms of our temple when we have any damage. So let's say there's a knock on the wall that needs repairing. the workers go down to the storage rooms to get, say, some plaster and some paint to make the necessary repairs. You've probably guessed that these storage rooms are our nutrient storage rooms, and it's really important that these nutrient storage rooms are full, but not too full, so that these repairs can be made effectively and efficiently with the right materials. So after a brain injury, it's like an earthquake has hit our temple. The damage is immense, but thankfully our workers get to work straight away to repair that damage. So after a brain injury, these storage rooms get depleted really quickly because of the immense damage, and the hospital medics and the hospital dietitians will be working really hard to refill those storage rooms. For many of our patients after a brain injury, it's not just the initial earthquake that damages our temple. There's also a number of aftershocks. So it might be further surgery, it might be picking up infections in hospital, it might be swallowing problems that further cause aftershocks to our temple. And of course, today we're talking about smell loss as well, which is another aftershock that goes on for a long time after the traumatic injury. So brain injury rehabilitation often starts in a state of malnutrition. It starts in the state where our storage rooms aren't full. So how is smell and appetite linked? It's a really important connection. Before food's even entered our mouth, we are breathing in these fragrant molecules of the food into our nasal cavity. And this acts as a communication. The olfactory receptors, which in this little diagram are those kind of yellow finger-like projections coming down, they will pick up the smell and send it to the olfactory bulb, and this sends it to a part in our brain called the amygdala and the hippocampus. And these are really important parts of our brain that are involved in emotion, memory, and learning. So even before we put that food in our mouth, we're having this emotional connection with food. This then sends communication signals to the brain to stimulate appetite. So before food's even entered our mouth, our appetite is stimulated. We'll increase salivation, which is the enzymes in our saliva help with the digestion process. We get more gastric acid produced, more gastric motility. So even before that food's come into our mouth, we're actually already preparing to digest it. And also smell will stimulate some of our hormones as well. So insulin, ghrelin, our hunger hormone, are also being stimulated here. So we're producing a picture of the food. We're producing a picture of, is this food safe? Is it desired? Then when it enters our mouth, we're further breaking down all those molecules, and the smell goes into the back of our mouth and up into our nasal cavity again. So again, we're asking ourselves, is this food safe? Do I want to swallow it? Is it desired? Then again, as we're swallowing it, again, this pushes up these fragrant molecules into our nasal cavity again. So what happens in smell loss or anosmia? Well, there's a real disconnect because we're not building up this picture, and there's a real kind of safety implication with that, as well as the kind of emotional and social disconnect that it causes. So we're not getting this communication to the amygdala and the hippocampus. We're not getting that emotional, that memory of foods. We're not getting the signals to the brain to start digesting the food that's coming. So this is going to have an effect on reducing our appetite and reducing the desire for the food and the picture of the food that's coming. We've got a question, is it safe? Is it desired? We actually don't know, because we can only make that decision from looking at it if we've got no sense of smell. So there's a real lack of control there, and an important safety issue as well. So when the food is going into our mouth, we can taste it because we have the 5 basic tastes, but we're not building that full picture of the food in our mouth. So again, it might not be as satisfying as if you're building that full picture. So you're just depending on your basic taste in your mouth. So you might therefore be able to taste the salt and the sugar in it, and therefore you might need more of that to kind of help stimulate your taste buds and form this picture of the food. And of course, this is all going to lead to reduced satisfaction and not getting the full depth of this experience. So smell disorders and the dietitian. Food is really complex, and it's important that we're not just looking at those storage rooms. It's important that we're not just looking at nutrition. There's a really important psychological side to food and a really important social side. And for myself as a dietitian, I have to be working in this space in the middle where I'm taking into account all these areas. So our relationship with food is also really important. And again, our relationship with food fits in the middle of all this. We need to be enjoying food. And if we've got a smell disorder, we're not going to get that same enjoyment of food. We might have a decreased appetite, which can be a real problem after a brain injury when we're trying to get those storage rooms back up, and the decreased appetite isn't going to help. There's a decreased trust in food, which is really important from a psychological point of view, the control of food, the working out if that food is safe. And there's a decreased satisfaction with food. And if we're not satisfied, we've probably all been in that situation where you're full, you've had enough to eat, you know you're full, but you're not satisfied by it. And we really need to be feeling satisfied by our food, because if we don't, we find ways of becoming satisfied with it. So we might add more salt to the food, we might add more sugar to the food. So all these things need to be taken into account, because otherwise we're going to get increased isolation for our clients and an increased disconnect with the food that they're eating. And all this can increase the risk of malnutrition, but it also can increase the risk of obesity and heart disease as well, particularly when we're talking about adding the salt, adding the sugar to become satisfied with the food. So I was just going to talk briefly about a case study that I have of someone who has anosmia after a traumatic brain injury. This lady is a female in her 20s, and she had a traumatic brain injury following a road traffic accident, and this led to anosmia. She lives alone and is creative in the kitchen. She's very social, and also has gastro symptoms. And some of the quotes that she gave here. So some things don't taste as good, some simply don't taste how they used to. So again, it's that lack of kind of memory of the emotional connection that she had with food. Sometimes hotter, slightly acidic. It's easy to be tempted to oversalt food, as it can really enrich the flavour. So here she's talking about adding chili peppers to her food, which is great because she's stimulating that trigeminal nerve. She's getting that satisfaction and the hotter to make the food hotter, spicier. She does have gastro symptoms, so that might not be the best thing in terms of them. But she's also very aware of how you can depend on these basic tastes and oversalt food to enrich that flavour and get that satisfaction. She says, I try to stick with recipes when cooking for others. And this is actually a really sad quote because she's incredibly creative in the kitchen. She just throws everything in. But unfortunately for her, because of her lack of smell, she doesn't have the trust in the food that she's cooking to be able to present it to other people. So she's feeling like she has to be restrained to a recipe to get it right. From a safety point of view, she talks about food burning or pans overheating is a big issue. I try to be diligent with the expiry dates, as I can't rely on smell. And the last one, it sucks, a big one, which I think sums it up really. So what can we do as professionals, and also as friends and family as well, when we know somebody has lost their sense of smell? It's really important that we're doing the investigations. I'm sure Dr. Philpott will talk about this more, but it's really important that we're ruling out other causes of smell loss. We're not just putting everything down to the brain injury. So for instance, there could be polyps in the nose or congestion. And it's really important that that's investigated. And of course, we know from the COVID pandemic as well that, you know, our clients could have a brain injury and COVID, which could be affecting their sense of smell. So there's a link there to the Fifth Sense website, looking at the clinics that are specialised in this. It's also really important that we're acknowledging smell issues, acknowledging where somebody is at. Quite often clients talk to me about not being heard, not being listened to when they talk about smell loss. It's just like, oh, well, if it's only smell loss. But actually it's a really big deal, as you'll hear tonight more. And it's really important that we acknowledge the smell issues that they have, and acknowledge where they're at. What can they smell? Quite often people will say, I've lost everything, I can't smell anything. But actually, when you look at different smells with them, there are some smells that they can detect, and that's really powerful and quite emotional. There's also some research coming out about the neurogenesis, these reforming of these olfactory receptors, and the benefit of smell training. So the benefit of smell training to identify the smell loss or where we're at the moment, but also to move it forward. Again, I've done this with clients, and it's just such an emotional experience to watch their smell improve over time. There's also mindful eating, really important. I won't talk about this too much because I don't want to step on what Deb Davies is going to talk about, but it's really important that we're feeling satisfied by the food we eat and we're enjoying it. Food should be enjoyed. So quite often I talk to clients about really looking at all their other senses when they're eating a meal, and even writing like a review on the meal they're eating. So even if it's something as simple as beans on toast, it's looking at the texture of that, the colours in that, what it looks like, so that we're really utilising those other senses. Also, there's some resource that we're hoping to pull out very soon. So please look at it on our website, keep an eye on that. It's a resource looking at the basic tastes and how we can utilise them more. So lots of practical suggestions. It's going to come out in a pamphlet, leaflet version. At the moment, it's at that painful stage of being edited and proofread and faffing about with it, really. That should come soon. And just two books that I'd really recommend as well. One is by Molly Birnbaum, who is called Seasoned Taste. And this lady was trained to be a chef when she had a traumatic brain injury and lost her sense of smell. So it was just incredibly traumatic for her to have lost that, such an important part of one of her senses. And she talks very descriptively about food and the trauma behind that as well. Also Ryan Riley, who has a recipe book called The Life Kitchen, and his mother actually lost a sense of smell due to chemotherapy and radiotherapy for cancer. So he started doing cookery workshops to encourage an enjoyment of food. So that's a really good book to read as well. I will hang around for any questions and answers at the end, but otherwise I will hand back to you, Duncan.
Thank you very much indeed, Sean. That was a brilliant presentation. Some really, really useful practical advice and information resources there. And I just want to pick up on one point that you made, really important point about the, the recognition and people often being dismissed. And, if I had £1 for every time that someone had said to me, well, at least it's only a sense of smell, then I'd be reasonably wealthy by now. I think it's this thing of this attitude that it's only a sense of smell. Part of the reason that I came up with the name Fifth Sense for the charity was to remind people that we have 5 ways in which we connect with the world around us, and they're all of equal importance. They just work in very, very different ways. And part of this is about saying that smell is of huge importance to our lives, but it's just often the way it affects us and influences us happens below the surface. It's not immediately obvious. But yeah, thank you very much indeed. What I'd like to do now is hand over to Professor Carl Philpott, who is going to give us an overview of the etiology and management of smell and taste disorders. So Professor Philpott is the Director of Research and Medical Affairs at Fifth Sense, we'll start the charity with, and is Professor of Rhinology and Olfactology at Norwich Medical School, and Honorary Consultant ENT Surgeon Rhinologist at James Paget Hospital. Carl, over to you.
Thank you, Duncan. Sorry, having a few technical issues here. Let me just see if I can load my slides. So hopefully you're now seeing what I'm seeing. Good. Right. Well, good evening, everyone. Thank you for attending this session this evening, and I'll try my best to give you a sort of an oversight of smell and taste disorders from sort of etiology through to management. I'm sure there'll be many questions, but we'll come to those as I go through. So yeah, I'll sort of touch upon the different causes of smell loss, give a quick nod to some of the terminology, look at how we take history from patients in clinic and the relevant examination investigations that we arrange. I'll make a special mention about the testing that we do for smell and taste, and have a little think about some of the evidence-based management and prognosis of smell and taste disorders. So Duncan's already kind of touched upon this issue of the sense of smell being thought of as the lesser sense, and for a lot of people it's only that moment of realization when they haven't got it that they realize how valuable it is to them. And I think this kind of quote by Oliver Sacks was quite pertinent. So how common is smell loss and what are the causes? Let's have a look at that. Essentially, there are lots of studies that have been done over the last 2-3 decades. None have been done in this country, so to date we don't have up-to-date evidence for the UK. But we can say that sort of the summation of the studies that have been done, we think approximately 5% of the population, and this is pre-COVID, were suffering with complete loss of smell, anosmia, and perhaps as many as 20% have some degree of olfactory loss or distortion. If you look at self-reported studies, the prevalence of smell disorders is somewhere between 1 to 15%. And if you look at it based on objective assessment where they've actually done testing, then it varies between 2 and 24%. So you can see that actually there's a bit of a disparity between what people are aware of, what people report, and what we can find if we do testing, and I'll come back to that issue later on. So we look at some of the surveys that have been done. So one of the sort of earliest was the National Geographic readership in the States, and that found that about 1.2% based on their little scratch and sniff booklets were rated as anosmic. More recently, we've got the Spanish newspaper survey that was done in Barcelona in 2012, And you can see that the rates of anosmia there were lower, but the rates of hyposmia, so that's a reduced sense of smell, were quite a lot higher. And they found that the risk factors for poor smell function were being a man, low educational level, previous head injury, and pregnancy and age. And then this graphic you can see there on the left-hand side was part of an international online survey done through a Google advert in 2013. And they've also nicely summarized a lot of the previous studies there. And you can see that if you look through the different causations, sinonasal disease, that's things like chronic sinusitis, comes as the top hitter along the top there, followed by upper respiratory infections, so that's typically viruses. And of course, we're familiar now with COVID-19 as one of those viruses. And then we've got the idiopathic cases, that's cases we don't find a cause for, and head injury, and then some of the lesser prevalent causes coming down the list. How do we compare to other sensory losses? So if we look at UK data for the Royal National Institute for the Blind, there are about 2 million people with a complete sight loss in the UK. And if we look at the Royal National Institute for the Deaf, there are about 0.8 million with profound hearing loss. So if we are thinking that anosmia is 5% of the population, then we're more than we're more prevalent than those sensory losses, and yet here we are with this sense that is neglected. This was another study done in the German-speaking nations of Germany, Austria, and Switzerland, and essentially this was looking at referrals into ENT clinics. So what was commonly being seen in ENT clinics, and for those of you who aren't conversant in German, the big chunk of the pie on the right is essentially the kind of nose and sinus problems, with the kind of 19% of the respiratory risk added in. So that big sort of 2 chunks of the pie of the nose and sinus issues. You could then see that the viral cause for smell loss was coming in there at 11%, with the unknown cause of 6%, head injury 5%, things caused by drugs and surgery 3%, toxic chemicals 2%, and then congenital 1%. The snapshot that I get doing a specialist clinic is rather different, because there's sort of a filtered view, and a lot of the sort of common nose and sinus problems often get sort of dealt with at a more general secondary care level. So you can see from my perspective, I have a slightly different view of things, with the big bar in the middle being the idiopathic cases, the 2 big bars on the right representing head injury and viruses, and the kind of peaks on the left, they're representing nose and sinus problems. And typically, if you pick up the sort of standard textbook, they'll say that each of those things is about 25% of what walks in the door. And that is true in a specialist setting, but not necessarily true in the general community. So just to summarize the causes of smell loss, we can divide those up into things that block airflow into the nose, otherwise known as conductive causes, representing about 70% of all causes of smell loss. And that's typically, as I mentioned before, the chronic sinusitis, but other things such as the deviated nasal septum, foreign bodies, unusual things like fungal balls, and obviously things that surgeons can do inside the nose, such as operate and then cause scar tissue, and that can obviously in itself cause blockages, or may remove tissue from the nose that is smell receptor bearing. The other causes which really affect the nerve pathways beyond the nose are what we call sensory neural. Viruses obviously can be part of that. Head injury could be part of that. And then there are other neurological causes, so stroke, epilepsy, and then the 2 that often people are familiar with, which is Parkinson's. So 90% of people at the point of being diagnosed with Parkinson's will have smell loss, and 50% of people with Alzheimer's probably have a degree of smell loss as well. And then there are a number of sort of rarer causes, as seen on the slide here. And of course, that I'm left with this kind of 1 in 5 people in my clinic who, despite full investigation, we don't find a cause for. So I said I mentioned terminology. We've touched upon anosmia and hyposmia, so complete loss and partial loss of smell. Parosmia refers to a distorted sense of smell. Phantosmia relates to the sensation of a smell without there being a smell present. We can break down parosmia further into unpleasant parosmia, known as troposmia, or pleasant parosmia, known as euosmia, although the latter tends to be rare. And then there's the term cacosmia, which tends to refer to an unpleasant phantosmia, but can sometimes be used to denote a bad smell that's internally generated. And we do see that from time to time with patients with certain types of sinus disease. And then with regards to taste, we use the terms agusia for absent taste and dysgeusia for taste distortion. So what are the things that I try to elicit when patients arrive in the smell and taste clinic? I'm keen to find out about the onset and timing of their condition. Those are often sort of critical clues as to the potential causation. And obviously, if people are aware of a particular precipitating cause, be it they remember specifically being unwell with a viral infection, they obviously were aware they woke up after a head injury with smell loss. Those are clear precipitating factors. It's good to know if patients have other symptoms from their nose, known as rhinological symptoms, if they experience these distortions, what we call qualitative disturbances. A lot of patients will come in talking about taste loss and be very certain that they can't taste anymore. Actually, a lot of the time when you explore what we consider taste medically, actually their sense of taste is fine. And then I'm interested, obviously, to know about their background medical history, any surgical history, and the history of any trauma where relevant. Also, medications can be important because some medications can have an impact upon both smell and taste. And it's also important for some people to know what their expectations from the consultation are, particularly if people are coming sort of many years after the onset of the problem. It's also important to understand what the impact is to that individual for the smell loss. Is it impacting on their physical health? Are they suffering with domestic hazards? Is it affecting their work, their financial security, their profession? Or are they having issues with social relationship and leisure issues? And those are often helped by our questionnaire that patients attending the clinic will fill out, called the Olfactory Disorders Questionnaire. One of the key things that we've sort of seen in some of the surveys we've done through Fifth Sense is that depression and anxiety are very common in people who experience smell and taste disorders. About a quarter in our study reported having received treatment in terms of antidepressants and counselling, and a further quarter had taken sort of over-the-counter remedies or alternative medicine therapies. And the other notable thing here is that people generally with their weight seem to go one of three ways. About a third maintain a steady weight, but a third will lose weight because of loss of appetite, and a third will gain weight because they seek takeaway foods that maybe give them some sort of stimulus, but are often poor nutritional value or high calorie content, and so they will gain weight. We also have looked previously about the number of people affected by these distortions of smell, what we call the qualitative disorders. Parosmia is certainly the most common of those two types of problems. And again, that can be linked to weight loss because of the revulsion that people experience because of their symptoms. We saw in our sort of cohort that the mean duration of symptoms was 7 years, but there was a huge range there, and ranging for 3 months to some people for several decades. But I would say that most people, it's probably on the lower side of that and closer to the lower end. So what do we do in terms of investigating these problems? The most important thing for me to do is obviously to look in a patient's nose with my endoscope to see what the nasal cavity looks like, to see what the smell receptor spaces look like, to understand whether there is any sinus disease, any scar tissue, any distortions of anatomy that may not be apparent from the history. Some patients who have a nose full of polyps, it's fairly clear when talking to them that they are talking like this, and you've already got the clue from listening to them that what you're going to find in examination. But some people may have polyps that are located more superior in the nasal cavity and actually sound just fine when you're talking to them. So it is very good to do a careful examination of the nose. And if I do suspect problems with the nose and sinuses, then a CT scan will be the most useful modality of investigation. But that's probably where that stops. And so A CT scan is really there for people with sinus disease or suspected sinus disease. In other cases where there's a history of head injury, where there isn't a clear cause, or if I suspect there may be some form of a growth or tumour present, then an MRI scan is the most appropriate form of investigation. For people presenting after a viral infection, there is no real need to perform any type of scan. It doesn't really add to the diagnosis. The diagnosis is usually clear from the history and confirmed by the examination. And I see a lot of people who have been imaged and scanned unnecessarily in that particular group. Now, we may use it in research studies, and that's a different kettle of fish. But for the primary purpose of investigating and diagnosing, it doesn't have a role to play in those cases. If the cause of the problem is not clear, then other investigations may be pertinent, including blood tests to look for more rarer causes, including metabolic disorders. And then the most important thing really in terms of investigation is doing smell and/or taste testing. But just a quick nod to imaging before I move on to that. The most important thing is if you do arrange imaging, and if you're a patient attending to sort of receive the results of imaging, is that the doctor really talks through the investigation with you. And these are a number of examples of scans where the scan was reported as being normal, or the patient was told that they had a normal scan. And in fact, actually, there was clear evidence of a problem on the scan. And you know, so for me, it's always very crucial to kind of look through scan, particularly previous scans, if patients have had them, and understand. In this example, bottom left, you can see that actually there is a complete loss of the air column in the smell receptor space at the top of the nose there. And so they're actually not getting any air circulating at all around the smell receptors. This scan was reported as essentially normal. The scan on the bottom right, there was a large focus on a small meningioma, which is a kind of benign tumor of the lining of the brain at the top of the scan, which you can't even see on that particular picture. The fact that the nose was full of polyps was completely unreported, and this patient went for 10 years before I saw them in clinic to tell them that they could be cured fairly quickly within 2 or 3 days with a course of steroids. Smell testing and taste testing. So the test we use here is the one in the picture, is called the sniffing sticks. That has 3 components to it. And the reason that we do this test is because it gives a much greater sort of broad view of how the sense of smell works. So there are some tests there which just rely on identification, which is the bit on the left of the test. And that's fine. You know, identification tests give you a certain degree of how people smell, but they are reliant on familiarity with smells and a verbalization of the name of smells. And the advantage of the sniffing sticks test and the other 2 parts of the test don't rely on that. You have no requirement to be familiar at all with any of the smells in the other 2 parts of the test, because the other 2 parts of the test discrimination, which is basically working out the odd one out in each set of 3, or threshold test, whereas we're actually looking for the concentration you can detect of one particular odor. And again, familiarity with the odor is not important in this part of the test. So the combined effect is that you get this at the end of the test, which is our printout. And you can see this was my test. I was actually suffering with acute sinusitis at the time. So you can see that my threshold was a little reduced. So I scored 4.5 out of 16. My discrimination was a little reduced. So I was getting 11 out of 16. And my identification was also reduced. So we're getting 10 out of 16. So my overall score was 25.5. And we expect a normal result to be 31 and above. And then there are other tests that we may employ in certain cases. So there's what we call a retronasal test. And this really mimics what happens when you eat, because when you eat, you're actually smelling the food inside your mouth. And so we can actually place powders on the tongue and ask people to identify the smell of that particular powder. But if we really want to taste true taste, then we use taste strips, which are placed on the tongue. As you can see, Jane, our research nurse here, is doing the so to me. And these alternate between the left and the right side of the tongue, testing the 4 basic tastes of salt, sweet, sour, and bitter. Why is this important? Well, this pie chart, or set of pie charts, explains exactly why. On the left-hand side pie chart, you can see these are what people attending a smell and taste clinic complained of. So you can see here that the large chunk of the pie being smell and taste loss, 20% saying smell loss only, 8% or 8.7% saying taste loss only, with other types of issues in the other two parts. When we actually test people, we find that nearly 70% have smell loss only, about a quarter have no identifiable smell or taste loss, and only about 1% of people are having true taste loss. And that really bears true in the results we see in our clinic. You know, only 1 in 100 people turn out would have a true taste dysfunction. So what do we do about it in these cases? First step really is sort of, you know, is there an obvious conductive cause? Because the conductive causes essentially tend to be the most treatable causes, and those obviously have a more defined pathway. We've mentioned about our testing. And the other thing really with the testing and the other investigations is it allows me to give the patient some idea of prognosis and where they're going to progress. It's a common sort of myth that there are no suitable treatments out there, and as you can see from evidence from our clinic, patients do get response to treatments. Not all do, but it is important to convey the message that there are some treatments available out there. However, there is some work to be done on treatments, and the reason for that is because a lot of the things that have been tried in various studies haven't been subjected to what we call the gold standard, the randomized controlled trial. And so many of the things there are sort of anecdotal evidence, and there'll be some things that those of us who are experts in smell and taste specialist clinics, sort of through consensus and through discussion with each other, will have some idea that they have a potential role. But we do need to do more work on actually demonstrating more concrete evidence to sort of underpin some of these. And that is certainly with one of my hats on, my ongoing mission to generate research funding. For the sinonasal causes, we can divide those into inflammatory and non-inflammatory. And these are many of the things we touched upon earlier in the talk. Sometimes patients may have a localized problem that's inflammatory within the smell receptor at the top of the nose that doesn't affect the rest of the nose and sinuses. These are a small number of cases, but important to identify and treat. So there are a number of key documents now sort of guiding clinicians in the area of chronic sinus disease, what we call chronic rhinosinusitis. And two of those have become out very recently. So we've got the European position paper, seen on the left here. This is free to download on the Rhinology International Journal website. And then on the right-hand side here, we've got the International Consensus Statement on Allergy and Rhinology, which has come out just this year. And this is, I'm not sure whether it's free to download this one, but it's only available through the International Forum of Allergy and Rhinology. And if patients have specific issues with their sense of smell that hasn't responded to the kind of conventional treatments for sinus disease, then there are sort of tricks that some of us have up our sleeve to help with that. And certainly one of those that I use is the use of this atomizer, which can actually kind of reach deep into the nose to the smell receptor area. And I can teach patients how to use this device and to deliver localized treatment to the right area of their nose. So moving on to the non-conductive causes, then there are all these sort of other things lined up. And these have to be kind of treated on a case-by-case basis, and you have to kind of work through on a personalized basis the best way to move forwards. Probably the sort of the group with most potential is the post-viral group, and there are a number of things, as I say, that have been mooted as potential treatments. The one that definitely has the most evidence behind it is smell training, which is, I think we mentioned already in the previous talk. We are just about to commence a trial of vitamin A, and I'll touch upon that shortly. We've done some work previous with sodium citrate, and there's been some work done in the States with theophylline which has now slowly started to become available as a nasal preparation in the UK. For head injury patients, it's important that they are assessed carefully to understand where the area of damage is. If patients present early, there may be a role for giving them steroids, and they may potentially, from evidence from other studies, gain to benefit from some of the things that help with viruses, but it really does depend on the information from the MRI scan. So it's really important to get that information together and understand individually for them where their potential lies. If we think there's a sort of other neurological cause, then for me, really, it's sort of passing them on to an appropriate neurologist to deal with. They may need scanning, but often we leave that to the neurologist to decide and provide appropriate counselling. For patients born without a sense of smell, then the MRI scan is really useful to understand whether they are missing the structures called the olfactory bulbs, which allow them to connect to the smell nerves to the rest of the brain. There are occasional cases where people seem to have absence of those structures and yet somehow have got some tenuous connection. So testing the sense of smell can still be relevant here to understand that. For people who present in childhood, then we need to get them seen by an appropriate paediatrician to check there aren't any associated hormonal disorders. And occasionally we do get people who present who have actually got a structural issue within the nose and do possess the olfactory bulbs, but have got essentially a blockage at the top of the nose, which potentially may be corrected. And then, of course, there's all the what we call the other group, or the case where we've got no obvious cause from history and examination, and we need to kind of work through those and test those and work out whether there's anything we can do to help. So in terms of the viral group, earlier this year we produced a consensus document from a group of international colleagues in the clinical olfactory working group, and we set out really how we think GPs and secondary care practitioners should be trying to approach these problems, and our guidance on what things they might want to consider in terms of treatment. And these were sort of our recommendations. So again, these are sort of touching upon some of the things I mentioned already. But we did subsequently produce a document around steroids specifically, saying that we don't feel that steroids have a direct role to play with treating viral smell loss. They just may have a role in improving, optimizing the nose for other treatments if there are things present like allergic rhinitis or sinus disease. And this was the kind of the sort of flow chart that we included in the document. So this is for secondary care practitioners, and we said the thing you should definitely do is encourage people to undertake modified olfactory training. We'll come on to that. The thing you may possibly do, as I say, mention steroids if there's a sort of need to kind of rule out a conductive component. And then the other things we mentioned here are things which have some degree of evidence for, but require further trial evidence. And the things on the right here are really the things that we, in our experience, have not found to be beneficial, that have really not supported by any good evidence and from practical experience. I guess a talk in this day and age wouldn't be complete without a quick nod to COVID-19. Obviously, in the last 18 months or so, we've seen a huge swathe of post-viral cases caused by COVID-19. And we estimate now in the UK, there's probably perhaps around 450,000 people with persistent changes in their sense of smell due to COVID-19. What we're seeing with these patients is that they're, excuse me, typically a much younger demographic, particularly now, obviously, because increasingly the older generations are vaccinated and protected. It's really now driving this problem down into the younger age groups, and I've certainly been seeing teenagers who I've never seen before with viral smell loss presenting in my clinic. Typically, these patients are getting sudden onset of symptoms, and the majority, obviously, of this is short-lived, but we think at about 10% are getting persistent symptoms. So we recently received funding from the National Institute of Health Research to undertake a proof of concept study for vitamin A drops in the nose. We've done some publicity with this over the last week, and already we've had a flurry of interest and people wanting to participate in the trial. So we'll be looking for 57 recruits over the next year, starting hopefully in December. and hopefully following that we'll be able to produce our evidence. And this is really looking at really the effects on the brain of the treatment before and after. So we're doing sort of brain imaging before and after the treatment. Head injury cases, just a quick mention to say that a head injury can have varying mechanisms of injury, and therefore can have various points along the pathway where the sense of smell can be lost. So it might be bruising of the brain, it might be stretching or severing of the nerve fibers as they cross from the nose into the brain. There may also be an injury to the nose at the same time, which may cause a blockage. And some of these patients may already have had a reduced sense of smell because of a pre-existing problem in the nose and sinuses. The reason we do the MRI scan is really to kind of try and localize that. So you can see in an example here, the sort of scarring of the brain in this area where the sense of smell is received. And obviously this, if we see it, it tends to be a poor prognostic sign. If we see an absence of findings, then that may indicate that the fine nerve fibers as they cross through have been injured. We can't see that on a scan, but it gives us an idea that that might be the, by a process of elimination, be the problem that's left. For these patients, it's important to sort of encourage smell training, particularly if there is an absence of severe findings on the scan, because longer term studies have shown that things may improve over time, and then we're talking about sort of several years, not just several months. So people have been told that if they haven't got some smell back within 3 months, isn't really borne true. It is true that if people are going to get it back within 2 to 3 years, but there is a tail, and the tail can last up to 10 years. And so we do see occasionally people getting it back over a longer period of time. The younger you are, the better that chance of recovery is. And particularly if we do smell testing and find there is some degree of preservation of smell function, that's obviously also a good sign. So I quick mention to smell training. I think many people are now familiar with this technique, and this was started sort of about a decade ago by Thomas Hummel and his colleagues in Germany, who got people to sort of present these 4 smells under the nose twice a day. And then that was taken a step further with what's called modified olfactory training, where this twice daily stimulation was then enhanced by changing the smells every 12 weeks. And you can see here in the MOT group, which is the modified olfactory training compared to the classical olfactory training, is that the increased sort of smell recovery. This is the smell test score here that we mentioned earlier. And you can see that compared to the control group, those doing the classical olfactory training got some improvement, but those changing their odors every 12 weeks got even better improvement. And considering 31 is normal, actually, they're getting up to a decent level of recovery here, which is encouraging. You'll see if you go to the FISSEDS website that there's our smellability toolbox and information about how to do this in your own home. You don't need any fancy equipment for this. It can be done with things in your own home cupboards, and it's all explained quite nicely here on the website. Obviously, important to consider other aspects, including sort of adaptations that need to be made at home and in the workplace, talking to family and friends, talking to bosses at work, talking to colleagues at work, if that's relevant, and also to think about how you might improve dietary enhancement to increase enjoyment of food. If people have these distortions of smell, then these can be more difficult to manage, and certainly, but there are certainly things we can do to try and help ameliorate with that, and those really are the remit of a specialist clinic, and these patients, if they have persistent problems, should come and seek that advice. So what's the prognosis? If you have sinus disease, then certainly there's a good chance, particularly if treated earlier in the process, the sense of smell can recover. But I do have had a number of patients who have come to see me 30, 40 years after the onset of their problem, have lived for 3-4 decades with smell loss, and with the right treatment have actually managed to restore the sense of smell. So there's it's incredible really to think that people have gone that long with a problem, but sinus disease is definitely the easiest one to crack. For people with viral smell loss, then we think at least a third will get recovery within 3 years. And this is kind of pre-COVID data. So how that looks for COVID, we're not quite sure yet. Time will tell. I mentioned about head injury, and about 1 in 3 people with head injury get some recovery within 5 years, with a suggestion that may creep up even further with that over 10 years. And in the patients who we don't find a cause for, it is important that we counsel people about the chance of developing Parkinson's or Alzheimer's. I often get asked if it's possible to cure people with smell loss. And I think really the message is that it's about treatment, it's about rehabilitation, it's about helping where treatment isn't available. And again, with sinus disease, chronic rhinosinusitis, adherence to treatment is really the key step to kind of maintaining a good sense of smell. And for some people, there are often sort of several issues going on, and we have to kind of pick through various issues to work out what is the one that's going to help them. It's important to remember that as with all our senses, the sense of smell declines with age, and that will be a factor for some people. But no assumptions should be made about the possibility of treatment until things have been fully evaluated in a proper systematic manner. You may have seen this sort of news. This is kind of, well, 7 years ago now, October 2014, where olfactory bulb cells were transferred to allow someone to regrow spinal cells and be able to walk again. So I often get asked why the reverse isn't true, and we haven't quite worked it out yet, but colleagues in other centres are working on stem cell therapies, and that may be something that comes to the fore in the years to come. So in summary, smell has both conductive and sensory neural components. Both aspects should be considered in the patient workup. True taste issues in isolation are rare, but certainly the role of taste is considering along with the sense of smell. Scans and blood tests may be appropriate in selected cases. Smell testing is important to aid prognosis and guide treatment. And there are treatments available, so people shouldn't be fobbed off, but they should also be realistic about what treatments are available and the need for coping strategies. And we definitely need to do more work on treatments. I thought I'd leave you with this sort of quotation from the film Patch Adams. You treat a disease, you win, you lose. You treat a person, I guarantee you'll win, no matter what the outcome. And I think for me, that's the philosophy for seeing people that come to the clinic. It's really about trying to understand what's right for that person and how we can help improve things for them. Some reading material, if you're a clinician, these are sort of some good sort of source reading. A couple of articles we produced in the British Journal of Hospital Medicine, and the book that Thomas Hummel and Antje Velgelusen have edited in Managing Smell and Taste Disorders. And I noticed that the previous speaker mentioned season to taste, so I've reinforced that issue. And also the book on the right called Aroma by Constance Klassen, which is a great read, understanding the cultural context of smell. So I'll stop there and ask for any questions.
Thank you very much, Carl, for that incredibly comprehensive presentation. Thank you very much. I'm sure there are probably quite a few questions that people are keen to ask. We've had a few coming in chat, and thanks for those. I'm conscious of time, so I think what might be an idea is if we move on to the next speaker, and then please keep popping your questions in chat. Carl, maybe we could tackle some of the ones that have been posted so far on the chat, and then any further questions, we're going to have the panel discussion later on. But what I'd like to do now is introduce Lucy Thomas, who's going to give us our first patient perspective of the evening, and what she wants medical professionals to understand about the impact that smell impairment has on our life.
Hi everyone. Sorry, the lighting's terrible here, but thank you very much for inviting me to share my story. about smell and taste loss. I live in London and I'm 43 actually, and my journey started back in March 2020. So it was before the first lockdown, and yeah, it was like the first wave of COVID, which crazy, like how much we know about COVID now. But at that time, there was no knowledge about COVID, the virus, but also about smell and taste loss. So I got symptoms, there weren't any tests available, and the NHS was completely overwhelmed at this stage. So I had the telltale cough, I got fatigue and aching, and I got quite bad breathing difficulties, which were a bit distressing. I can't really remember if it was actually the GP or 111, and their advice was actually just to call an ambulance if my lips turned blue, which was pretty terrifying. But thankfully I recovered fine, just at home with rest and plenty of paracetamol. However, a week after the symptoms started, I had sudden loss of smell and taste. It was immediate and it was complete. So really different from having a stuffy nose where things don't quite taste right when you've got a cold. I could literally eat mustard out of a jar and have absolutely no sensation. So no taste, no trigeminal, certainly no aroma. This wasn't a recognised symptom. And obviously I was scouring the internet and Twitter, and I did find a post from Iran actually, which indicated this could be linked to COVID. My career is in food and drink. So I'm a product developer and I do recipe development for startups as well as corporate companies. So as you can imagine, I was pretty distressed and worried. I furiously searched the internet and learned everything I could about smell and taste disorders. I learned about smell training and started that straight away. I got in touch with fifth sense. And actually quite quickly my basic tastes, so the sweet, sour, salty, bitter, umami, and also the trigeminal sensations returned really quickly within a few days. So I was feeling a little bit happier about that, but still absolutely no smell. And Duncan talked about it, but it really is impossible to imagine how disorientating, isolating and worrying it is to lose your sense of smell. We all get these little micro moments of joy throughout the day that we just take for granted. It could be like the face cream that you apply, the more obvious food and drink occasions, the smell of the outdoors, and even the smell of like your favorite people and pets. Without these, it's like your life really feels flat. And I honestly felt completely hopeless about a future without smell. I also burn a lot of food. You don't realise when you're cooking the signals you get constantly about whether something's ready or about to caramelise or burn. And I certainly felt vulnerable to dangers of, well, fire from burning food, but also dangers like gas leaks, chemicals, especially cleaning chemicals, smoke, and of course off food. But really slowly, but definitely there was an improvement over the next couple of months. And I'd say probably over 2 months, I had about a 50% return in my sense of smell. And, you know, at this stage, people were talking about the sense of smell link with COVID. And lots of people, you know, the majority of people, it comes back really quickly. I was in this really small proportion where it was taking longer. But, you know, it gave me confidence knowing that smell was returning. And I think the first thing I smelt was a tiny hint of cloves. I was doing my smell training, but I was also frantically smelling everything in my kitchen. And each time a new aroma returned, I was just over the moon, and I was definitely doing little victory dances around the kitchen. So I had a lot of hope at that stage and felt it was just a question of time and I'd soon be back to my super taster status. But then at the end of May, I sat down to breakfast and it was egg and it tasted absolutely disgusting. My boyfriend at the time said his breakfast was fine, and then it hit me like a sledgehammer, really, because obviously when I'd researched smell and taste disorders, I'd heard about anosmia, which gives these unpleasant distortions. And really, that was always like my benchmark for, oh, well, at least I don't have anosmia, because that sounds awful. And here I was, going from this hopeful state of recovering quickly to complete hopelessness. And so over the next few days, I guess I was in like some kind of real life bush tucker trial, discovering my kind of triggers. And there's some quite common triggers. It's very different and each person's unique, but typically coffee, wine, beer, chocolate, meat, eggs, all the nice things, and particularly onion and garlic are a few of my triggers. There wasn't really any logic, and some days one thing was fine, the next day it was absolutely rank. A lot of food was ending up in the bin. I was definitely hungry. There was very, very little food I could eat without triggering these really intense, unpleasant distortions, and it was pretty upsetting. The smell can't really be described, the COVID kind of anosmia smell, and I think it probably is different for everyone. But for me, and what's commonly reported by patients, is that it's somewhere between a kind of sewage smell. So yeah, it's pretty awful. And the intensity of it is so offensive. And if you have a trigger, so if I eat something with garlic, it lingers for hours, sometimes days. And you can't even freshen your mouth by cleaning your teeth, because toothpaste, mint was one of my worst offenders. So it's fair to say that at this point, the effects on my quality of life were absolutely devastating. My GP, so my GP gave me no options for referral, no empathy at all, no support, and certainly no treatment. And as Sean mentioned and Professor Philpott mentioned, it really would have made a world of difference to get some empathy and recognition of what I was going through at this stage. So thank you to everyone who's joined this evening, because awareness is certainly key for the patient. Because of my career and the importance that my business relies on my sense of smell, I self-funded private treatment with Professor Carl Philpott. Hi, Carl. I've tried steroids, I've tried nasal rinsing, vitamin A, theophylline, gabapentin, and I've also tried numerous supplements, alternative therapies. I've probably spent thousands in total. Also, I've had cognitive behavioural therapy and meditation to help with the anxiety and stress. And I'm fairly sure I should probably see a nutritionist. I've certainly had some anemic, low iron results since COVID, so perhaps Sean, I'll be in touch about that. So have the treatments helped? I don't know. There has been an improvement. I do have a long list of safe foods that I try and stick to, which is the range has improved, and there are certain foods like cheese which have been great all the way through. So I've also found a lot of hacks to help me cope. There's flavour-free toothpaste, for example, and certainly the fifth sense support has really helped me discover ways of improving my diet and range of foods that I can eat. But I still get really anxious eating out. My meals are really boring. and I'm sure that I'm missing key nutrients. I keep trying the foods that are unpleasant every so often, because some of them do change. So lemon, for example, was awful and it's much better now. Tastes pretty good. But some smells are still really badly distorted. Some smells are completely absent. Many are reduced, and some are actually fully normal. So it's a real mixed picture 18 months on, but I've certainly got a long way to go. It's really great to know that parosmia is, although it's a horrible thing to experience, it is actually a good sign, and recovery from smell loss is probably more likely if you get parosmia. So that's really my story and where I'm at. I'd just like to really say thank you to those who have attended, because it really is important that smell loss is taken seriously, and somebody who has smell loss or parosmia probably isn't okay. So just offering some support as well as treatment or referral could really make the world of difference. And a huge thank you to Fifth Sense, who did show me the compassion and have supported me through what's been a really difficult time. So thanks very much.
Thank you very much, Lucy, for that incredibly powerful testimony. And I'm sure it's really, I'm sure you've really highlighted to people listening today, the impact that, not just smell loss, but the distortions of the sense of smell parosmia can have. And, once again, you've highlighted something that I touched upon and that Sian also touched upon as well, is this, the recognition that this is challenging, understanding that it kind of affects our lives in so many different ways, and work with us. That's part of the message, I suppose, to healthcare professionals, is listen and help us find a way through this. I think this brings us on quite appropriately now to our next speaker. Delighted to welcome Dr. Rachel Hertz from Brown University in the US. And Rachel is acknowledged globally for her work around the emotional impact of smell impairments. And she's going to talk more about the psychological impacts of smell loss. Rachel, thank you.
Thank you so much, Duncan. It's a pleasure to be here. I'm really thrilled to be able to share what I'll be talking about today. I'm just going to try and share my screen now. I have slides. So I really also appreciate everyone who's spoken before me, because I think it really lays a wonderful foundation for what I'm going to be speaking about. And in fact, I'm going to be talking a little bit more than just the psychological components of smell loss, and really get into the whole quality of life issues that are so fundamental to losing one's sense of smell and that have been touched on. And I hope to broaden that slightly. So without further ado, the most obvious aspect of smell loss comes from our pleasure of experiencing food. And this has to do with the fact that, when we think about chocolate aroma, I'm sorry, just one second. I wanted to back up. I think I have the wrong talk up. I just want to make sure that this is the one. It starts a little bit differently. Just one second. One second. Sorry about that. Oh, no, sorry, 1 second. I spent all this time waiting to get started, and then I have the wrong talk up. So I did this twice. Okay, here we go. I'm very sorry about that. And hopefully you're back. Nope, I don't think I'm sharing my screen again. Okay. Okay, here we go. I apologize. What I wanted to do actually is jump into explaining the unique neuroanatomy of olfaction with other systems in our brain, which really kind of set the stage for how smell loss really does disrupt our psychological life and quality of life in so many different facets. And so this has already been mentioned briefly by the other speakers, but I just wanted to point out right here, these little purple things right here are the olfactory bulbs, and they're direct projections from the brain, basically at the level of the eyebrow. And unlike any of our other senses, the first synapse in the brain after the olfactory bulb is with the amygdala, which is where emotion and emotional memory is processed, as well as the hippocampus, which is also where learning and associative learning takes place in various forms of memory. And in fact, what's known as the amygdala hippocampal complex is also referred to as the primary olfactory cortex. That is to say that where smell is processed in the brain is exactly the same as where emotion, emotional memory, and learning and memory are also processed. In addition to that, we have the hypothalamus, which is part of the limbic system. It isn't as directly tied to the olfactory centers as the amygdala and the hippocampus are, but it is very, very deeply and richly innervated by it. And this is involved in our motivations in general, our food behavior, and also sexual behavior. So just to summarize, our sense of smell taps into emotion, emotional memory, learning, associative learning, also spatial orientation. This has to do with the fact, I'll be speaking about this also, that our cognitive skill set and our ability to navigate is actually also tied to our sense of smell. And as I also said, motivation, including food and sexual behavior. So going back to food, when we think about the pleasure of food, we think about the fact that we are eating, let's say, delicious chocolate cake or some sizzling bacon. And most people use the word taste erroneously, and they are not referring to the basic taste sensation of these foods. They're referring to flavor. And flavor is the fusion of a basic taste, in the case of, let's say, chocolate cake, sweetness, so sugar, with the aroma of chocolate, which then results in the experience of chocolate cake. And in the case of bacon, it is the pure taste of salt with bacon aroma that then results in the sensation of the flavor of bacon. Now, for someone without a sense of smell, they do not get those aroma sensations and are only left with this experience of either just sweet or just salt. And this is, as the previous speakers have mentioned already, an extremely difficult state of being and leads to a variety of health problems that evolve from this impairment. And first of all, we have basic nutritional problems. And the fact that without a sense of smell, all kinds of things can happen, from not being cued of when meal times are, and this can be especially dangerous if the person lives alone, and also if they're not very social, and particularly during COVID and lockdown when people were much more isolated, not having a sense of smell can lead to malnutrition in various ways that actually, for some people, can look as though they're demented because they're not, in fact, getting the nutrition that they need. But as soon as they start eating properly balanced meals, they become cognitively normal again. There's also the issue that foods that are high in sugar, high in salt, and high in fat are in and of themselves very hedonically rewarding. The hot spots of reward and pleasure in our brain light up purely by these oral sensations alone. And if you are not getting the pleasure from chocolate cake, of the aroma and all the deliciousness you had from it before, you can at least say, well, you know, it's creamy and it's sweet. And likewise for bacon, you can say, well, it's, you know, fatty and it's salty. And so those are positive sensations, which people then tend to gravitate towards in terms of food. And this can lead to various issues. And it's already been mentioned by Professor Philpott that you have these weight changes. And often what starts off happening is people tend to gain weight by trying to, let's say, eat to the, you know, they're searching for that food that they really want to experience, and they're eating and they're eating and they're eating, and it's just not happening. And so, but during this process, they end up gaining weight. And then what happens is they get so despondent and discouraged by the fact that they're not getting the reward and the pleasure from food, they start eating much at all, and they tend to lose weight. And so there's this kind of yo-yoing, which also from a health perspective is not very good. But in my experience, actually, the overall overall experience tends to be the weight gain. And that has to do with the fact that over the long term, people tend to resort to the more positive experiences of salt, sugar, and fat. And so that leads to a less healthy diet, other metabolic issues that can come along with that, and weight gain in the long run. Now, related to food is the issue of food safety. And in fact, about 2/3 of people with anosmia report not being able to detect food spoilage. Now, of course, we can use our eyes, but the actual smell of things are the most important signal for when things are no longer edible and could be in fact dangerous to eat. And the fact that anosmics typically say that they are not able to detect food spoilage really underscores that this could be an important health and safety problem, especially because the Food Standards Agency of the UK reports that about approximately 2.4 million people a year in the UK come down with foodborne illnesses, which can be quite severe. So food safety is part of the quality of life issue and overall health and safety and well-being issue that people with anosmia face regularly. They also face the issue of general home safety problems in not being able to detect natural gas or methane. And for people who have stovetops and cookers that use natural gas, we cannot actually smell these chemicals, and the gas companies typically add a special bouquet that often smells like skunk or sulfur, depending upon where you live. And this is a signal that, for example, your pilot light has gone out, or that there's a buildup of some kind of gas in your house. And another example of this is also carbon monoxide, and having an auditory trigger for recognizing that these are problems is something that everyone in their house should have. In fact, I have been involved in a lawsuit here in the United States with someone who in fact died because, and they were not anosmic, but they were asleep. And interestingly enough, when you are asleep, your ability to smell is shut off. And they had a buildup of carbon monoxide in their house, and their house in fact exploded. So in any case, very, very tragic. But the point being that everyone needs to rely on other signals for potential buildup of noxious and toxic gases. But for somebody without a sense of smell, the normal methods, which are actually to add other smells, does not work at all. And so this can end up being, extremely catastrophic depending upon the circumstance. And I've also worked with people who've lost their sense of smell, who have had near miss situations, which could have been completely fatal. So moving from that, now we're getting into the part where I guess I've spent the most of my research working on, which has to do with emotional well-being and also the more cognitive aspects of the psychological toll of smell loss. And one of the major issues relating to loss of smell is depression. And that is actually directly connected to the fact that the olfactory bulbs and the amygdala are synergistically interacting in a normal, healthy, functioning person. However, when someone has lost their sense of smell, the typical input that would be going in to innervate this entire system is cut off by half. And that actually leads to malfunctioning in the other half, that is the amygdala, and also, as you'll see, the hippocampus. And as a function of that, depression, not just because your life has taken this complete other direction without a sense of smell that you never expected it to have, and you're recognizing all the tragic things that you can't experience anymore, but directly as a function of the neurological interactions between the processing of smell and the processing of emotion, people can develop clinically severe depression. And unfortunately, because, and this is particularly the case when smell loss is permanent, which thankfully for most upper respiratory tract viral infections, this is not the case. And also it's hopeful that for at least 90% of COVID patients who have lost their sense of smell, this will also not be the case. And, it's still, the jury is out because we don't have enough data yet how long-term people with smell loss will persist in their lack of ability to smell who've had COVID. But nevertheless, when you've had smell loss from a traumatic brain injury, for example, which is very easy to have happen, all you need is a really hard blow to the front of the head or the back of the head, which shears off the axons from the olfactory sensory neurons in the nose as they're going into the brain. And this trauma in and of itself wouldn't necessarily be devastating because olfactory sensory neurons themselves, in fact, regenerate all the time. But typically what happens in any kind of traumatic brain injury is the porous, very, very thin bone called the cribriform plate that the axons of the olfactory sensory neurons pass through. In fact, it becomes inflamed and these little tiny holes scar over, and that prevents the sensory neurons from being able to get into the brain in the first place. Although it does seem that even smell training may be able to help this a little bit. But in many cases, this can lead to permanent smell loss. And as a function of this interaction between the sense of smell and emotional processing, as time progresses, the deterioration in that system also progresses, and emotional well-being deteriorates further and further. So this can be actually a really dangerous state of affairs psychiatrically. Relating to the various emotional aspects of life that become derailed when someone has lost their sense of smell, and this is again typically what one sees in long-term scenarios, is that people become obsessed with personal hygiene and are constantly worried that they're emitting unpleasant body odors, breath odors, and so forth. But they also tend to become quite paranoid, and even people who live with other people and who ask them to, can you please check that I'm not, smelling bad, will stop believing them. And as a function of this, and are bathing constantly, they'll start to make all kinds of awkward sort of decisions like, can't leave the house because I have to basically have a suitcase with me with a change of clothes in it because, we're only going for half an hour, but just in case I might smell and so forth. And this can lead to another serious side effect of the emotional impact of smell loss, which is reclusiveness. And people who just then decide, it's not worth going out at all in the first place because of the fact that it's really distressing to me and I don't know what's going to happen, as well as a feeling that has been brought up by the previous speakers, and especially Lucy and also Duncan's personal experiences, that people just don't understand. And it's just not worth trying to explain to other people what I am going through because they don't get it. They don't get me. I feel really isolated in and of myself, just in a room with 20 other people because of this lack of understanding and empathy. And the decision then to become, stay in starts to become more and more attractive. And that in and of itself has a variety of problems relating to mental health, as we've all seen through the isolation that the pandemic has caused for people who have, normally functioning set of five senses. So reclusiveness is a response, but it can also be part of what then escalates emotional despair and a worsening emotional life amongst people with smell loss. Another dimension of one's personal life that becomes, unfortunately, less positive with long-term smell loss is a breakdown in various social relationships. And this can be particularly the case for women, but also for men. But it can be seen especially when women who want to start a family. I worked directly with someone who was in her late 20s, had a, normal, happy life, professional, newly married, was planning on starting a family, but then felt that because of her smell loss, she wouldn't be able to, number one, bond with her baby, which she felt very, very disturbed about. And mother-infant bonding as a function of smell is a very critical component of early emotional development. And in fact, infants can recognize the specific smell of their own mother within an hour after birth as a function of the shared amniotic fluid, and mothers can do the same within literally minutes of having given birth, recognizing their own newborn from other newborns. So this especially intense emotional bonding was something this person worried about, as well as the fact of even being able to detect things like illness and so forth, which are often given off by changes in body odor and so forth. And then worrying in general, as Lucy said also, what if I burn the house down while I'm trying to cook something? What if I do this? What if I can't recognize that? And all the dangers and concerns that a mother would have about keeping her child safe. Like I said, that, father, male caregivers as well, but this is traditionally something that women tend to worry about a little bit more. And connected to that is what happens with sexual relationships, which for both men and women can falter as a function of loss of smell, where the person feels they can't feel the sort of intimate sensations of the other person because they can't smell their body odor, they can't sort of feel connected to them sort of beneath the skin in a way. And especially this can be something which is difficult for women, because research has in fact shown that women's ability to orgasm is related to their ability to smell. And so women who've lost their sense of smell often cannot get real satisfaction from sexual relationships, and therefore as that on top of the feeling that they feel disconnected from their partner can make them feel that they no longer want to engage in intimate behavior, and this can lead to a breakdown in the relationship itself. And as I mentioned earlier, this other aspect of our sense of smell, which is only recently becoming more and more sort of known within the research world, is how our spatial ability, our ability to navigate in space in the world, is connected to our sense of smell. And this has to do with the connection between the olfactory processing areas and the hippocampus, which is involved in spatial mapping. And various studies have shown that people with a fully functioning sense of smell can follow smell trails. They can build spatial maps out of scent cues in a particular kind of a space. And people that I've worked with who have lost their sense of smell have told me on numerous occasions that they felt lost in both sort of a general sort of philosophical way, but also very specifically, and have told me that they can't do a variety of things with respect to their jobs and daily life that they used to do, like taking the bus or learning or going to, following directions to get somewhere. And relating to this is what can happen with executive functioning problems. And this also connects to people who have TBI, traumatic brain injury. Even if it's very minor, people who also suffer olfactory loss can have profound deficits in executive functioning. So executive functioning comprises sort of two sets of major tasks that we all do all the time. One is emotional regulation and self-control, so not having an outburst in the middle of a meeting, for example, and the other is being able to plan and focus and pay attention and follow tasks through and so on. And I've dealt with a number of people who've told me that they can't do their jobs anymore, especially when they involve complex problem solving and dealing with other people, as a function of this executive functioning decline, which happens with losing one's sense of smell. And now moving along to another aspect of cognition, which is extremely important when it comes to our personal life and also with olfaction in general, is how scents can be such a powerful trigger for personal, poignant autobiographical memories. And we also know of the example of Proust, who, had a Madeleine biscuit, which he dipped in linden tea, and then that flavor, it was actually the retronasal olfaction, the aroma of that Madeleine with the linden tea, that brought back his long forgotten memory of his aunt's house when he was a child. But all of us have, if it's not, maybe not lots of them, but we all have had some kind of a memory that's triggered by a scent that brings us back to a time and place that we might otherwise have completely forgotten. And in fact, in even just a small scale, our life is an amalgamation of all of our past autobiographical memories. And so many of them in different aspects have an olfactory component, even if it's not the central one. And when people lose this, they really lose a piece of themselves. And so fundamentally, people who have lost their sense of smell really feel, often, it's not everybody, but often, especially as I said, in long-term cases, that they have lost their sense of self, and that they really are adrift in a sea of confusion that is not getting any better. And especially because, at least up until very, very recently, and hopefully this is changing, one of the things I feel that, the sort of silver lining of COVID is how it has brought awareness of loss of smell to the general public much more, also to the medical community much more. But really the fact that so many people, as you've already heard from today, deal with this feeling of isolation, deal with this lack of empathy, deal with a sense that no one understands them, and that this contributes even more to a feeling of a sense of self that has, really fallen apart. So to summarize, our sense of smell is critical for really just about everything that we experience as the sort of color of life, and for much more beyond that. So we have the enjoyment of food, we have our physical health, we have our emotional health, we have social and interpersonal relationships, we have a whole host of cognitive skills, we have our personal memories, our sense of self, and our overall quality of life. And a mission of mine has been to try to make people aware of this who have a sense of smell that has not been compromised in any way, so that they can take the time to stop and smell the roses or the leaves. And I thank my dog Zoe for posing for this picture. So thank you very much. Anyone out there?
I'm here. Thank you very much, Rachel, for that fantastic talk. That was brilliant. Thank you. And just that point that you made towards the end about COVID and the increased awareness, and yeah, I totally hear you, because it made me think now. I've friends and family who over the past 18 months who've had COVID and lost a sense of smell for a temporary period have spoken to me and said, I get it.
Mm-hmm.
I get it. I get why you did this, you know. So every cloud does have a silver lining, and you know, I hope that more people are going to be aware now. And I think also your final point, that really positive message, is that, you know, we've got this incredible, wonderful, powerful sense that all too often we take for granted. And, you know, the message that we're sending out is, you know, value it, use it, and appreciate it. So
Exactly.
thank you very much for joining us. Thank you.
Thank you. Thank you, everyone. Thank you, Duncan. Thank you, Fifth Sense.
Okay, great. Thank you very much, Rachel. Okay, moving on to our next speaker then. We've got Debs Davis, who I had the pleasure of meeting for the first time last year. And Debs is going to be talking about what she wants healthcare professionals to understand, and talking about the value of mindfulness. Debs, over to you.
Thank you very much, Duncan. Good evening, everybody. Hopefully you can see my screen now. I'm really pleased to follow Rachel in the presentation this evening, because I'm going to talk about the value of mindfulness and how that can support emotional well-being in people who are experiencing smell and taste disorders. Just a bit about me to start with. I'm a congenital anosmic, and I can't remember when it was exactly that I realised that I couldn't smell. Most congenital anosmics will tell you of a point in time when they realised that they couldn't smell. But of course, when you're congenital anosmic, it's always been that way. So there needs to be something that actually makes you realise that it's not like that for everybody. And I can't remember when that was for me. I know I knew as a teenager, because I've spoken to my friends about it and they remember me not being able to smell. And I also remember being at university and being on the tram, and there was a little boy who was on the tram with his dad, maybe 2-3 years old, something like that. And he was scrabbling around on the floor, and his dad said to him, "Don't do that, it's dirty." And what he did is he took his hand up to his nose instinctively and smelt his hand. And I just thought, that's something I would never do. It would never occur to me to put my hand to my nose if somebody told me that something was dirty. Because of course, that's just the way it had always been for me. And it wasn't really until a completely chance conversation with an ENT consultant in somewhere in the kind of mid-90s that then led to investigations which concluded that the olfactory bulb couldn't be detected on an MRI scan, and a diagnosis then of congenital anosmia. But of course, the mid-90s was kind of the era of Alta Vista and dial-up modems, so it never really occurred to me to do any more research than that at the time. But the reason for talking about that is that I'd got my hopes up. You know, I'd got my hopes up that something could be fixed and that I would be able to smell. And then, of course, that they got dashed. Fast forward then to about 3 years ago, and I came across the work of Carl Philpott in an article somewhere. And I thought, I'm sure that imaging has improved in the intervening 20-25 years. I'm sure now that an MRI will be able to detect something that it couldn't detect 25 years ago. You can see that I got my hopes up again that something might be there that clearly wasn't. There was no change. And then again, I got my hopes up very recently when I heard somebody say, actually, they'd never come across a case where the olfactory bulb was missing. And of course, I started to think, well, maybe I misread the consultant's report then. Maybe there was something there and I've just misread it, but I hadn't. But the reason I talk about this is not to talk about me, but it's to really demonstrate what an important role hope plays in anosmia and people that have, particularly people that have acquired anosmia. And I'll talk about that a bit more in a moment. Now, I think from my point of view as a congenital anosmic, I had always appreciated that my experience was different from somebody who had acquired anosmia because I hadn't experienced that loss. And I also know, and particularly having listened to what Rachel has spoken about, I also knew that I had a number of compensating behaviours. So I would typically take a toothbrush with me and sometimes a change of clothes and things like that when I would go to particular places, not everywhere. So I was always aware that I had some compensating behaviours. But I always felt that yes, there were issues with safety and not being able to smell, but I had always felt that that didn't diminish significantly my quality of life. But I did appreciate that that wasn't the case for everybody. So it never really occurred to me that I had something that I could perhaps offer to people with anosmia until COVID came around and of course shone the spotlight on it. And it just got me thinking, really, you know, I realized that I navigate the world every day and always have done for all of my life in the way that people have to now. So how can I sort of decode what it is that I do, you know, and how I navigate the world in a way that might be helpful to other people? I had the privilege of listening to Rachel talk earlier in the year, and this really struck me when she said that people with anosmia adapt less well long-term than people who lose other senses, particularly their sight. It really struck me, that fact, and, you know, really got me thinking about, as I said, about what might help. And of course, there are many reasons for that kind of that adaptation or the lesser adaptation over time. But one, of course, is this delicate balance between hope and between acceptance. And that's why I was talking about the hope that I'd experienced at the start of this presentation, just to give you a sense of how significant that can be for people with congenital anosmia, let alone people with acquired anosmia or parosmia. So this sort of delicate balance, I think, for people with acquired anosmia, we've heard people talk tonight about having a virus, and we all know people who've experienced smell loss as a result of a virus, and for most people it comes back. So there is an expectation that when there's a loss of a sense of smell, that smell will come back. Whereas with some of the other sensory losses, that expectation perhaps isn't as strong or doesn't exist at all in some cases. So I think with smell loss, we know that it's possible that there's recovery. So that balance between the hope of the smell returning and the acceptance that it might not is a really, really tricky balance to strike, I think. And if we think about it, if we err too much on one side, for example, if we kind of go more into acceptance, we assume it means that we have to lose hope. So we haven't got that kind of even balance. We've got more acceptance. We assume it means we have to give up hope. And, you know, a very kind of British response is kind of going, oh, well, it is what it is. It's just going to be a bit rubbish. But if we reframe that idea of acceptance as acceptance is the final stage of a grieving process, then I think that puts a really different perspective on what acceptance means in the case of anosmia. It's really kind of allowing that possibility that we can live well with it without losing the hope that it might actually return. And the thing is, if we err the other side of that and have only hope and a resistance to any acceptance, if we've got all of that hope, we pin so much on the recovery, and we pin our long-term well-being on the possibility of recovery of that smell. And our total focus then is about what's absent, how things are changing, whether what we're doing is working or not, and a real focus on absence and loss and an urgency around that recovery. So we know that that pressure and that anxiety that we feel about those things takes our attention away from actually what's happening in the moment. When we are ruminating and feeling very anxious, it takes us up into our head and out of that mindful awareness about what's going on. Now, you know, that balance is very, very difficult to find. And, you know, I in no way diminish the impact of loss at all. But how can we help people to find that balance in a way that doesn't diminish their experience? You've heard a number of people tonight already talk about how their own experiences can be diminished when they talk about their experience of loss and how they feel about it. So I feel it's really important to recognize and acknowledge that that loss, those feelings of loss are there. But at the same time, how can we help people to get that sense of emotional well-being and living a full life back? And for me, really, it's that shift between if I get my sense of smell back, then I'll be able to live well, versus a sense of, I really hope it comes back, and I know I can live well if it doesn't. Again, I'm not saying that that balance is in any way easy to find, but this is where mindfulness, I feel, can really, really help. You know, helping people get back into what's going on in the moment of their experience and away from that sense and that feeling of loss that they may be experiencing. So what is mindfulness then? It's that the quality or the state of being conscious or aware of something. So it's all about bringing our awareness back into what's happening, into our life and in the moment. So if we look at how we navigate the world, as I think it was Duncan said before, we have all of our five senses, if we have five senses, that enable us to navigate the world. And the way I sort of talk about it to people who have lost their sense of smell and to people who haven't is just in very, very simple terms. I talk about our senses as being like a computer program. And if we lose one of them, whichever one it is, but we're talking about smell tonight, it's a bit like a bit of a computer program that's been deleted or distorted or corrupted in some way. So we might go about our day-to-day business doing something that we've done a million times before or we do every day. But all of a sudden we're doing that same thing again, but there's a bit of the computer program that's deleted. So of course, as Rachel said before, of course, we're going to feel the emotional impact of that. Of course, that's going to create a sense of threat in our brain and a feeling of anxiety as a result of that. That's natural. We're going to become very, very aware of what's missing. But as Duncan said, we've got 4 other senses. And as I say, that's in no way to diminish the impact of loss. But if we can use that mindful awareness to tune back into the senses that we do have, so we bring our awareness to what's there and away from what's not there, and to navigate in that way, then that to some degree will help people to get a sense of emotional well-being back. And again, I'm not saying that that's easy, but I experience emotions, and I know that Rachel may say I have more of a flat affect than perhaps people who have been able to smell previously. But I don't live my life filled with anxiety and fear. I do create memories. I do have emotions, And at the same time, I also relate to so much of what Rachel said, particularly the spatial awareness issue. I am not great at navigating. So there are definitely things in what Rachel says that impact me, and to a degree impact me significantly too. But how can we use the senses that we do have to tune back into our environment to increase our sense of emotional well-being? How do we train our brain that it's safe to live without our sense of smell? And there are a number of ways that we can do that. And this is not about saying, just focus on the positives. It's not about doing that, not at all, because I think we all know that that doesn't really help very much at all. My approach to it is very practical. It's about how do we apply these mindfulness practices to help our day-to-day life. For me, it's not necessarily about having a meditation practice, although somebody could if they want to. It's about how do we use these in a very practical way. So it might be helping people to become more aware of what they can perceive in the moment. So it might be drawing your attention to the colours on my shirt as I'm talking here. You might be noticing the spots or something like that on my top, or drawing your awareness to the way I'm talking, what my intonation is, what the speed is as I speed up and I slow down. Or it might just be bringing your awareness to the chair or sofa or bed that you may be sitting on now and the feel of that against your body. Just really using those other senses to bring your awareness more into the moment, into what you're doing right now. And then also helping people to access those historical memories that might be primarily related to smell in some way, shape or form, but allowing and encouraging people to access those through their other senses. What can you remember seeing in that memory? What about what you could hear? What did you feel in that memory? And using those to really give people a sense that those memories are, there was more to it than the smell there. And also in everyday life, how we relate to people, to places, and to things, how we go about our day-to-day life, whether we're on transport of whatever kind, whether we're in particular venues, and in particular things like going out to eat. It's one of the things that I think people with acquired anosmia in particular will frequently say to me that is the thing that they really don't like doing anymore. But for me, it would be about, well, what else can you sense? What else is there that you can pay attention to and increase your awareness of? Because I enjoy going out for food. Food is quite functional to me. I will say that it is quite a functional thing. But for me, going out is that sense of connection with other people, the things that I can see, hear, the way I feel when I'm in connection with other people. And so it's about helping people to go about their day-to-day business and responsibilities in a different way. And finally, one of the things that we've talked about quite a bit tonight, various speakers have talked about, is that sense of safety. How can we bring awareness to our other senses when safety is really essential? How can we use things practically like timers or other ways to keep our attention present when we're cooking or doing other things where danger is present? So again, as I said, this is not by any stretch underestimating the impact of smell loss on somebody's emotional well-being. And it's not in any way suggesting that mindfulness is a fix-all for the impact and the emotional impact that this can have on people. But what I really want you to know, having said all of that, and having explained how mindfulness can help, is really something that echoes what everybody else has said this evening. Please don't underestimate the emotional impact of anosmia or the extent to which that journey to being able to live well with it, how long that will take, or how intense that might be for some people. So that's it from me. I have just started a Instagram channel. If you're interested in finding out more about how mindfulness can help, you can find me at The Mindful Anosmic. That's it from me. Thank you.
Debs, thank you so much. That was absolutely brilliant. Really, really powerful. And I think some really, really sort of positive messages there. And it, you know, this idea of mindfulness, of focusing on what you do, you know, what you do have, is really important. It's something that I myself have done, particularly around food. I've sort of become really aware of the elements of the eating experience that I can still appreciate in the absence of flavour, texture, temperature, spiciness, and really sort of focus on those and use all the principles that Debs has been talking about when enjoying a meal. So this idea of using the things that we do still have as a way of trying to help compensate for a loss or lack of smell or taste can be quite helpful. Debs, thank you so much again. And moving on now to our final speaker of the evening. We are running a little bit over. The RSM team have very kindly said that we can continue past 8 o'clock. So please stay with us. And I'd like to introduce Richard, who's going to be Dr. Richard Rees, who's going to be talking about neurology. Over to you, Richard.
Thank you. I'm just going to try and set up my screen properly. With any luck, this is going to work. Oh gosh. Unfortunately, I was delayed leaving the hospital, so didn't manage to get to the setup portion of the webinar, and I'm just struggling to get to where I need to be. So hopefully this will do it. I am aware we're quite a way behind, so fortunately, being the last speaker, I'm standing on the shoulders of giants, and a lot of what I was going to say has already been said, so that will speed things up. Let me see what you can see now. That's the wrong thing. So bear with me. Right. Hopefully you can just see a single slide. Is that correct?
Yes, we can see a single slide, but there's no text.
Okay.
Are you sharing you got dual screen?
Yeah, I was hoping that you would see something saying smell loss in the brain.
No. If you stop sharing and share your other screen, please, because I think you're sharing the wrong view.
Right. Okay. Sorry about this, everybody. I'm sure I'm not the only one that can't wait to get back to in-person events again. There's a lot less that can go wrong.
If you have your PowerPoint ready on your desktop, you should be able to identify which screen to share.
Yeah. Right. I'm just going to unplug the other screen.
That won't make a difference, to be honest.
Okay. Sorry.
So if you press your share screen button, and then when you get the white box appears in front of you,
yeah.
Can you see your PowerPoint anywhere within those icons?
I can.
If you can see your PowerPoint, then highlight your PowerPoint and then press the blue share button, please. Okay, we've still got a white screen. So do you want to advance forward, see if there's any text coming through? It's just a blank white screen at the moment.
Okay.
You could see your mouse cursor, but not your text.
Are you seeing anything?
No, nothing. It's just a white blank screen at the moment.
Okay, just a minute then.
Have you got your PowerPoint in front of you?
Yeah.
That you could see the text. Okay. Yeah. Share the other, where you see it displayed on your other screen, share that screen for us, please. Because at the moment, all we're seeing is the white blank screen.
Yeah, I will do that. Just a second. Right.
That's it. Yes. That's great. Thanks.
Okay, super. So, apologies for that delay. So I am Richard Rees. I'm a neurology registrar. I'm really privileged and honoured to have the opportunity to talk to you about my perspective on this, which is, as you can tell, smell loss and neurology, and how the smell can be a window into the brain. Through my research, having spent 3 or 4 years in research, I've travelled across the UK visiting people with idiopathic smell loss. Duncan briefly, Carl briefly spoke about idiopathic smell loss. And I met them and I did detailed assessments, but their stories have echoed so much of what we've heard today. And in terms of how popular smell loss has become, the graph on the right is the number of publications on PubMed that are about anosmia. And so, as you can see, I got in there around here, so before it was cool to be talking about anosmia. So I want to introduce James. This is James, and when he was 45, he was working as an accountant and he liked to swim. He joked with his friends that his wife always chastised him for burning the cooking. Then a few years later, he saw his GP because he had frozen shoulder. He didn't mention any of the food issues to his GP when he asked for some laxatives a few years later, and he told his friends that he was generally feeling a bit blue. At 56, he was surprised when his wife told him that the gas had been left on, but he couldn't smell a thing. And by 59, he was slowing down and noticed he kept hitting the lane rope on the left-hand side when he went swimming. By 61, he was having real difficulty doing small DIY projects. And towards the end of the talk, we'll come back to James. So over the next, hopefully only 10 or 15 minutes, I want to talk about how smell loss how smell travels through the brain and how it interacts with important brain areas. But given that we've heard quite a lot about that, I might skip through that for time. And we'll look at 3 different kinds of neurological disorders that are impacted by smell, from the hyperacute to the very chronic. So just briefly, this is a diagram of smell through, it's actually smell through a macaque monkey brain, but the human brain is very similar. So in blue, we have the frontal lobes, and in yellow, we have the temporal lobe. And smell comes in from the air up through the nose, as we've heard, and through the first of the cranial nerves, the olfactory nerve, to the olfactory bulb. And from there, it goes to the primary olfactory cortex, which is the olfactory bulb and nucleus, as we've discussed, the entorhinal cortex, the piriform cortex, and the amygdala. And we've heard all about these. And these structures are incredibly well preserved when you look back phylogenetically. So smell has been a crucial part of survival way before the invention of the human. And in fact, the piriform cortex, which is what the olfactory nerve has its first synapse, its first connection with, is even seen in amphibians and reptiles. So it's a pre-mammal structure within the brain. So smell comes in, and comes into the primary olfactory areas. And from there, it goes in several directions all at once. The first is to the orbitofrontal cortex, which is this structure right at the front of the brain, directly overlying the eye sockets. And the orbitofrontal cortex lights up when subjects in a functional MRI scanner are asked to make judgments based on smells, or make predictions based on smells. And the smell also goes via relay stations, and the primary relay station of the entire brain is the thalamus. And it can go to the thalamus and then to the orbitofrontal cortex, where it takes on an extra layer of complexity. So in this circuit, the orbitofrontal cortex and the thalamus light up when people are assessing how right or wrong they are with regards to those predictions they've already made, and also controlling olfactory attention. And I'm sure most people here that have had a sense of smell at some point have been stuck in a tube train or a lift when it's been quite important that you can divert your olfactory attention away from something, or when you've been in a nice restaurant and divert your olfactory attention towards something. But the the orbitofrontal cortex also synapses with the thalamus. So you get another connection from the orbitofrontal cortex to the hypothalamus. And as we've already heard, the hypothalamus is involved in a huge range of hormonal control over the body, including satiety and hunger. But also, as Rachel mentioned earlier, things like sex and emotion as well. And speaking of emotion, the other major route that olfactory signals take is to come from the olfactory cortex down into the temporal lobe and into the limbic system. And the limbic system has got, amongst other things, the entorhinal cortex, the amygdala, and the hippocampus, which is one of the main memory area of the brain. The limbic system also controls emotion and social behavior. And this relates back to what Rachel was saying. It wasn't just Proust that has those smells that trigger memories. I'm sure many of you have been out and about or somewhere, and you just get this whiff of an odor that immediately transports you back to your grandparents' kitchen when they cooked that beef stew that you always remembered them cooking. And it triggers these incredibly strong memories, and not just memories, but emotionally salient memories. So we've already heard about traumatic brain injury quite a bit, and this is the first disease area because it's an area that's gaining a huge amount more attention within the world of neurology. So about 20% of people in the UK that have had traumatic brain injury go on to develop or also have smell loss. And it comes as no surprise that the severity of the smell loss is proportional to the severity of the brain injury. And just looking at this figure on the right, you can see the very fine olfactory nerves that go through these trabeculations and the cribriform plate, which is this fine meshwork of bone that separates the top of the nose from the olfactory bulb. And if you fall off a ladder or an airbag explodes in front of you at 60 miles an hour to try and save your life, that's not going to do a great deal of good to your to these very delicate bony structures. But then also after that, you get the shearing forces of the brain moving backwards and forwards in the skull, smashing its way into the front and the back. And although the cerebrospinal fluid acts as a physical shock absorber, that shock absorption is quite quickly overwhelmed in significant trauma. And so you not only get direct damage to structures that I've already spoken about, such as the orbitofrontal cortex, the entorhinal cortex, the piriform cortex, but also you get shearing forces throughout the brain. And in this functional MRI study that looks at networks of smell throughout the brain, you see that smell is not just dedicated in one or two areas that I've spoken about, but as we're understanding more about the brain and how the brain can go wrong, especially in traumatic brain injury, it's not just damage to one particular part. Each particular part is part of this electronic network, kind of like the World Wide Web. If you take out one computer, not much happens, but if, like happened with Facebook and Instagram yesterday, if you knock out the network, then all access is denied. And this is what we're seeing. And one final point that again links in with so many of the talks that we've had today, there is a strong relationship with depression in smell loss in traumatic brain injury. So to explain that differently, if you take 100 people with traumatic brain injury, those that have smell loss as well are much more likely to be depressed than those who have the traumatic brain injury without smell loss. And that's even correcting for the severity of the brain injury and other factors. So it's been hypothesized that this may be due to damage to the orbitofrontal cortex, which, as we've discussed, is important in the processing of smell, but is also a key part of the reward pathway. So, moving on from traumatic brain injury to something that comes and goes through life, let's talk about epilepsy. And in particular, we're going to talk about temporal lobe epilepsy, which is one of the most common types of focal epilepsy that we see. So it's very common for people with epilepsy before they have a seizure to have some kind of aura. So that's a feeling, often a sensation. Could be a feeling of doom. It could be a feeling of heat coming up from their stomach. But in about a third of people that have auras, what they get is a very strong smell. And I've included this picture of the burning rubber at the bottom because it's very common for people to say, the first thing I get is this intense smell of something really quite horrid or acrid. And people often talk about the smell of burning rubber. And then the next thing they know is they've woken up and they might have bitten their tongue or been incontinent or hurt themselves because they've just had a tonic-clonic seizure. We've talked about the temporal lobe and the hippocampus and the piriform cortex. And we know that the studies comparing people with epilepsy compared to controls have shown that all types of odor awareness, so that's both identification and memory and discrimination, the different modalities of smell that Professor Philpott talked about with the sniffing sticks, are worse in people with epilepsy, particularly temporal lobe epilepsy, compared to controls. And that's even when accounting for other differences. And then we also see this crossover of temporal lobe epilepsy with olfactory pathways, as we've discussed. And there have been studies, and this was a publication from I think this year or last year, that showed that that looked at data from various studies and how the people with epilepsy have significantly worse sense of smell, and often the focus of the epilepsy is in the piriform cortex. And this is a slightly oblique angle in the bottom right, sliced through the brain, where you can see the piriform cortex abutting the amygdala and then the hippocampus. So these are very closely and directly connected structures. And finally, let's look at Parkinson's disease. This is an area that I feel a lot more comfortable talking about, as it's what my research was in. So if you take everyone with Parkinson's, about 90% of them will have smell loss. And even at the point of diagnosis, about 70% of them have lost their smell. And that isn't even with complex smell testing using sniffing sticks or the other psychophysical testing of smell. even if you just ask them, tell me about your sense of smell, they'll often say, oh yeah, now you come to mention it, I've never really thought about it, but now you come to mention it, I don't really smell things anymore. There's a big study of normal aging that is taking place in the Pacific Islands, the American Pacific Islands, called the Honolulu Asia Aging Study. And they performed various kinds of assessments, including memory assessments, movement assessments, but also smell assessments in life as people got older. And then they had about 165 participants give their brains for examination after death. And there was a very, very striking finding, which was that people who were in the worst third of smell function in life were 17% more likely to have the same pathology or pathological proteins that are seen in Parkinson's compared to people who had normal smell in life. So we now have a very clear and strong link between Parkinson's pathology, smell loss, epidemiology. And the slide on the right is from Heiko Brack and his seminal paper in 2003, looking at how Parkinson's pathology spreads through the brain. And what we can see is this area in the bottom figure, in basically the darker something is, the earlier it's affected. And this is the olfactory nerve, and this here is the medulla. And there's a hypothesis that's gaining a lot of traction, which is that Parkinson's starts in one of two places. It either starts in the body and comes up through the medulla into the brainstem, where it affects the substantia nigra, which is the main area of the brain that's affected, and then it travels throughout the rest of the brain, and that's where you see such many of the devastating complications of Parkinson's, like dementia and hallucinations and psychosis. But the other alternative explanation is that it comes in through the nose. And there's a really lively debate going on at the moment within the Parkinson's world about exactly what the nature of the spread of Parkinson's is, and even how Parkinson's is caused, it may be transmitted, and we don't have many of those answers yet. But what the research I've been involved with, and there are several large studies in Europe, in the UK and in the US, is trying to identify people at the very earliest stages. And this brings me on to my last slide, because at the moment, we diagnose people with Parkinson's at the point where the arrow is on this timer. And that's when they have the clinical movement difficulties that have been bad enough to get them to see their GP, get their GP to refer them to a neurologist, wait for the neurologist to see them, and then they get the clinical diagnosis. And there's no blood test or scan that diagnoses Parkinson's. It's a constellation of slowness of movement, or otherwise called bradykinesia, along with tremor or rigidity, that gives this clinical diagnosis. But we know through many studies, in fact, I'm going to go back one slide. This is a study looking at people with a condition that usually ends up in Parkinson's disease or similar conditions, called REM sleep behavioral disorder. It's a kind of sleep pathology. And they followed people prospectively, testing them in many kinds of ways. And what they found was that in those people who went on to develop Parkinson's, and in fact, I copied the wrong slide, but the slide for smell loss was very, very similar. What they found is that smell loss probably started about 20 years before these people with this sleep disorder went on to develop Parkinson's. And so we're seeing from multiple different avenues of research that smell loss in a small number of people is potentially predictive of Parkinson's disease. I want to stress that this is most likely to be a small subset of the people who have what's otherwise been previously defined as idiopathic anosmia. So it isn't going to be the trauma. We don't think it's going to be the post-viral olfactory loss. It's the people who have just gradually, slowly had their smell dwindling away and have kind of put it down to aging or something else. And so what we're trying to do in the Predict PD study is identify people at the very earliest stages of Parkinson's, such that when we do eventually have a potentially disease-modifying treatment, these people could be selected for clinical trials or ultimately given a treatment that might slow down or even arrest the progression of Parkinson's, such that they never get to this horrific end stage that's so devastating for the individual, for their family, and actually costs about £3 billion a year to the UK economy. So let's go back to James. You may have guessed, given how this talk has gone, that he did go on to get Parkinson's. And as I say, maybe in a few years' time, at that first point where he notices that he's burning the food a lot, he's starting to get constipated, he's a bit depressed. These are all signs that could possibly just be explained by the unfortunate continuity of time, but also in the right constellation could be suggestive of progression of a neurodegenerative disease. So we've looked at a whistle-stop tour of how smell travels through the brain, building on the excellent talks we've had this evening. And then we've looked at how smell loss can be an important feature and lead to depression in traumatic brain injury. We've looked at the overlap between temporal lobe epilepsy and smell loss and how many of the structures are crucial to both. And we've looked at smell loss as a possible very early symptom or harbinger of Parkinson's disease. I hope you found that stimulating and interesting, and we may have a few minutes of questions for the entire group. So I'll hand back to Carl and Duncan.
Richard, thank you very much indeed for that. That was a brilliant talk. Thank you. And that's really highlighted something that we hadn't covered up until you spoke. The fact that the smell loss is associated with certain neurodegenerative disorders as well. It's not just about either the acquired or congenital anosmia that we talked about previously. Conscious of time, I've been told by our RSM colleagues that we've got until 8:30, so that leaves us 5 minutes for questions. So I'm going to throw the floor open, and if anyone's got any burning issues they'd like to ask one of our panel, then please fire away. Just having a quick look in the chat.
Take something from the chat.
Yeah, I was just going to say, Carl, do you want to pick one out from there?
So there's one here about, has there been an increase in new cases of anosmia in this decade, and what portion of them are known to have tested positive for COVID-19? So, yeah, as I mentioned in my talk, I mean, the numbers of people affected in the UK we don't truly know, and in fact, it's well, I'm hoping there's a bit of funding application later this year to kind of to answer that very question. So COVID-19 is likely to have changed the kind of epidemiology of smell loss and skew it more to viral cases. But obviously we don't know at this stage how many will spontaneously recover, because it's still relatively early days yet within COVID-19 itself and how that's evolving. It's difficult to comment on that, really. I think, an aging population does generally point to the likelihood that more people are affected by smell loss, because we know the sense of smell declines with age, and for the things that Richard's covered in his talk with regards to neurological disease, obviously an older population is more likely to experience those conditions. And so that's maybe what we find out in an updated epidemiological survey.
Regarding Alzheimer's, dementias. The jury is, I think, still out on that. I was looking at this recently and looking at some of the studies that have suggested that link, and it's difficult to say. A lot of the data is confounded by the fact that they haven't corrected for other quite important variables. So haven't corrected for things like smoking or other conditions that can lead to smell loss. So because Alzheimer's and dementia in particular is so common in the older age group, it's quite easy to get spurious correlations and to see relationships that aren't necessarily true. However, I think Parkinson's is different, that I think there is a much stronger triangulation of the evidence from pathological studies, epidemiological studies, from all kinds of different directions, that we are really a lot more confident that smell loss is an integral part of Parkinson's. And the jury's still out regarding some of the other neurodegenerative conditions. There's a question in the chat about neurotropic viruses like herpes zoster. Certainly herpes simplex virus, which is the most common cause of viral encephalitis, has a propensity to go for the temporal lobes and is incredibly destructive incredibly quickly. And I haven't seen any studies on it, but I would put my mortgage on the results of a study looking at smell loss post herpes simplex encephalitis, showing severe and profound smell loss. But I'm not aware of that study having been done.
Anything else in the chat? There's a question here about neurogenesis for congenital anosmics. I mean, not that I know of at the moment to say that there is work on sort of stem cell therapy. There has been some work on olfactory bulb grafting in rodents, but that's not progressed to a human model yet. So, you know, perhaps there may be something we do in the future. A lot of people ask about sort of implants because in my specialty we implant the ear, the cochlea for hearing loss. The difficulty is for some of the anatomical and physiological reasons that have been explained during this talk, to replicate that for the sense of smell is going to be a much greater challenge. I think it'll be a very clever person who manages to solve that conundrum. So there's a comment there about rugby players, footballers and boxers about chronic trauma. Maybe makes me think maybe we should be getting the Premiership to fund some smell-related research in the future.
I think one Premier League footballer's salary ought to add quite a bit of value to research landscape.
Might be a whole research lab, that would.
There is a huge amount of research now being done with the Rugby Premiership and the FA into traumatic brain injury in sport. I will ask some of my colleagues that have been involved in that whether or not they're doing olfactory testing. But when you look at the noses as they do the national anthems and the camera goes along the starting lineup, you would not be surprised, given the state of the multiple broken noses that they've all had, if smell had been affected.
Yeah, food cauliflowers in their ears in there as well.
Mm. Okay, thanks. I've just had a message from our colleagues at the Royal Society of Medicine to say it's time to wrap up this evening's events. So are there still any questions that we've not answered yet, or are they all covered? I think they're all covered. Brilliant, thank you. Okay, which brings us to the end of this evening. I would like to say huge thank you to our fantastic panel of speakers. It's been a really great evening. We've covered a lot of ground, and I know we could have probably talked even longer. So thank you all very much indeed for sharing your experiences and expertise with us this evening. A huge thank you to the Royal Society of Medicine for all your support of people affected by smell and taste disorders and Fifth Sense's work over the past few years, and looking forward to continuing to working with you. And then finally, thank you all sorry, I'm starting to coming to the end of the evening for me, clearly. Thank you all very much to everyone who's joined the webinar this evening. I really hope you've enjoyed it and found it very useful. A couple of quick things from me. It's great that we can do these online events now and share so much information that way. Fifth Sense is we're holding our 2021 national conference in Manchester on the 20th of November, which is a face-to-face event. We're going to send out details on that to you by email following the event. And we're also going to send out an evaluation form. We'd be really great if you could fill that in, because that'll give us some really useful data in terms of help us measure the impact of our work. And then if you'd like to get in touch, if you've got any need for any further information following this evening, head over to our website, www.fifthsense.org.uk, and contact us that way. And thank you all very much.